All right, everybody. Welcome once again to Careers Unlimited EKG course. Today we'll be discussing a continuation of the arrhythmias in the heart. We're going to discuss bundle branch blocks today, which is in chapter 10. As you know, we've talked about a variety of different arrhythmias that can occur in the heart. We've discussed atrial arrhythmias. We discussed AV, atrioventricular arrhythmias. We also went into ventricular arrhythmias, and now we are going to discuss the bundle branches, which is part of your electrophysiology of the heart. It's part of your electrical pathway. Remember, your SA node is your primary pacemaker, and then the signals, the impulses are trickle down through the atrium into the AV node, then into the bundle of His. Right after that, they separate into the left and right bundle branches, and that's what we're going to be focusing on today. The arrhythmias that can occur as a result of injury or tissue death to the bundle branches. So what is a bundle branch or block? Yeah, the impulses that are blocked that control the heartbeat can move properly through the heart. So if you remember, there's two, left and right. So you're going to see a change in the R wave. Remember that the R wave represents the left and the right on the branch, one the left and one at the right. So this is where you're going to be seeing the main changes. So forget the P wave, right? The PR interval. We're going to be focusing mainly on the R wave. So the wave cannot move properly through the heart. Okay, blocking the branches causes the impulses within the ventricles to travel slower than normal. So if they're slower, that means then you have probably a longer R interval, which the normal is 0.06 to 0.10. It should be the expected duration of the R wave. So you probably see wider than normal R waves. The right bundle branch occurs in the right bundle branch, so that current has to travel down the left bundle branch to activate the ventricles. So if there's a block, the impulses cannot travel through the right. That means that only the left bundle branch will be taking the impulses and taking it down into the ventricles. Therefore, how does the right side of the heart then get motivated or activated, okay, or depolarized? So the electrical activity that travels down the abnormal pathways, not your bundle branches, takes longer to achieve full ventricular depolarization. So that's why you see the abnormal duration. This conduction delays results in a wider than normal QRS, and the longer time frame is similar to driving a car, right, to a specific destination. I think we've taken that analogy and out of their arrhythmias. And anything that has to do with a block, right? Whether it be an AV block or ventricular block, or in this case, bundle branch block, use the analogy of driving from destination B to destination B. Whenever you have a detour, there's traffic, right? You have to take a different route. This is kind of the same thing, same analogy, right? The signal is going to get there. It's just going to take a little longer than usual. So when a patient has the right bundle branch, the impulses will travel down the conduction pathway normally until after the bundle of His. At some point, the right bundle branch is blocked. This may be due to what? Infarction, which is tissue death. So if this happens, of course, the impulse will not be able to conduct in a normal way. So you're going to see the changes in the electrocardiogram. The ventriculars will not complete the depolarization via the left bundle branch. The result of this change in direction results in the classic RSR pattern. RSR. What it means is that you're going to see a notch in your R wave. Instead of being a nice pyramid looking or pine looking R wave, you're going to see R, which means you're going to have a little peak and then it goes back up, and you're going to see, so R, and you have like a little notch down like this. That's going to be your S, and then it goes back up. That's another R. So you have R, S, R. Okay, that's what it means in the right bundle branch. Okay, right bundle branch will be on the left. If you're looking at the EKG and the R wave specifically, if you see R, remember that's going to be your first upward is your R. Then you got one down, S, and then R. That's going to be a right bundle branch block. And some people call it the rabbit ears because they kind of look like rabbit ears, so just two pointy peaks. In the left bundle branch, the left conduction pathway is blocked. Current travels down the right bundle branch to cause the right ventricles, the septum and the left ventricle to depolarize. This results in a wider than normal and negatively reflected QRS when viewed on lead V1. In this bundle branch, typically the underlying rhythm is a rhythm that originates from above the ventricles, whether it be an AV rhythm or a sinoatrial rhythm. Normally has a narrow QRS, can be affected by the bundle branch block. The presence of bundle branch block causes a widened QRS complex due to the delay of the electrical impulse as it spreads through the ventricles. The discovery of a wide QRS complex is a clue to further investigate for the presence of bundle branch blocks. Of course, these are not normal. Now, this may be something that the person has a history of. Maybe they have had a heart attack, which damaged the branch, the right or the left. So you'll see a normal, abnormal EKG on a person. The patient may be experiencing sinus rhythm with a left bundle branch. The basic rhythm and underlying rhythm must always be determined and specified along with RBB or left bundle branch. So let's look at an example. On page 247, you see the picture of the conduction pathway, right? The sinus sends off an impulse, travels to the left atrium, down, right? The tissue into the AV node. Here in the AV node goes to the bundle of His, passes into the left and right bundle branches. But if you see on the right bundle branch, there's a red spot and indicating that there is an injury or an infarction. Part of that tissue is dead. So the signal cannot travel further down and depolarize the ventricles, in this case, the right ventricle, okay? So you see on the EKG right below that diagram, you look at the P wave, and then you have the R, and then it S down, okay? And it looks negative. It's a negatively deflected wide QRS. To look at this specific bundle branch blocks, it's better to view them on lead V1 or the chest leads V1 or V2. So let's go through the criteria for classification. So the rhythm, again, it may be regular. So use your calipers, right? You're gonna notice that they're pretty regular. All the impulses are occurring at the expected time. Sinus ratio is usually the underlying rhythm with both regular and irregular. The rate should be within normal. In this case, we have a rate of 3, 4, 5, 6. You have 60, which is within the normal. The P-wave morphology. P-wave morphology depends on the underlying rhythm. If it's a sinus rhythm, then you should expect normal P waves, right? Upward, deflected, round, and well-shaped. If you have an AV rhythm, atrioventricular rhythm, then you should expect or not expect any P waves at all. So right away, if you see P waves that are not there, they're missing, or they're after the QRS, then it's probably an AV rhythm. If you remember, because the AV junction signals backward, sometimes you have inverted, right? Inverted P waves or notched P waves, or they're hidden within the QRS, or they come after the QRS, then that's an AV rhythm. So you have to identify the underlying rhythm and then the left or right bundle branch. The PR interval is going to vary depending where the impulse is coming from. A normal PR duration should be between 0.12 and 0.20. Again, sinus rhythms will have a normal PR interval, whereas AV rhythms will have a variety of durations. The QRS duration morphology, the QRS measurement, again, 0.12 seconds or greater in length. So you have a wider QRS. The widening of the QRS duration indicates the presence of a bundle branch block. So there's a delay in the impulse. how the patient is affected. Is the patient affected because of an inverted or delay? Well, it depends, right? How much of the delay, how often is it happening? The longer the impulse takes, the longer the ventricles take to depolarize. That means going to result, the end is decreased cardiac output, right? If the rhythm is sinus tachy, the patient will exhibit signs and symptoms of a fast heart rate, depending on the speed or the heart rate. If it's, with the patient can tolerate 120, right? They might feel the palpitations, they may feel their heart being a little faster, but still feel okay. Again, it's going to depend on the patient as well. If the current becomes totally blocked and the current cannot reach the myocardium, it's considered a complete heart block, which is kind of goes with what we talked about in the other impulses or the other rhythms when you have a first degree, second degree, third degree heart blocks, right? Except there we were talking about the AV junction where the impulse is completely blocked. Okay, we have here a bundle branch block where the impulse is partially blocked, so the ventricles may partially depolarize. Bundle branch blocks are not considered to be life-threatening, but the condition can cause bundle branch blocks or complete myocardial infarction, which of course is life-threatening. You can look at the widening of the QRS. This should be reported obviously right away to the nurse or to the physician. Excuse me. Monitoring could help. In this case, oxygen is always the primary measure that we implement. We give the patient oxygen, supplemental oxygen, to help that heart get more oxygen, to help alleviate some of the maybe the ischemia or lack of blood flow oxygen to the muscle tissue. All right, so what happens when one or both of the ventricular pathways are not functioning properly due to damage or delay from cardiac disease, drugs, or other conditions? We have a partial bundle branch blocks. Describe the electrical conduction RBB and LBB. Well, in the right bundle branch block, we see that the impulse is blocked. It could be at any point. It could be at the beginning where it branches off. It could be in the middle or way at the end. Same thing for the left bundle branch. The blockage could be at any point, any part of the branch itself. So in checkpoint questions, LO 10.1, we see, what do we see here? Which one most resembles a bundle branch block? A or B? Again, use the criteria for classification. What is one of the main criteria for a bundle branch block? A wide QRS greater than 0.20. So if you look at A and B, the choice is pretty obvious, right? So can you name A? Take a couple of minutes and use the criteria of classification. Remember to identify the underlying problem. If you look at A, you see P waves, correct? You see P waves. So pretty much they're all there. The PR interval looks about the same. And then you look at the QRS. What's wrong with the QRS? They're a little wide, right? The little cones look a little bit wide. They may be 0.16 or actually greater than 0.20. And the rate is a little slow, it's 50. And letter B is what? What could we call letter B? There are P waves. Or is it regular? You get calipers and they look pretty regular. The QRSs look within the normal range of 0.06 to 0.10. So then what would we call this one? This one would be called a sinus bradycardia because everything is normal about it except the heart rate. It's low, less than 60, so that make it a bradycardia. Right? So if you didn't get a chance to thoroughly evaluate it, again, slowly go back and look at the 5 criteria for classification, and you should be able to determine the difference. Do not forget to name the underlying rhythm. So in letter A, we would call it a sinus Brady because the rate is 50. The rate is regular. Sinus Brady with the left or the right bundle branch. We would call this probably a left bundle branch. Okay, so with that, let's continue to look at the differences between the left and right bundle branches on section 10.2. When monitoring leads 1, 2, and 3, the characteristics of LBB and RBB will be the same. Specific characteristics of the right or left bundle branch will present when monitoring on leads B1 through 6. Why? Because the bundle branches are located, or they run down the septum, which is the one that divides the ventricles, the left and the right ventricle. So the tissue of the bundle branches runs right down through it. So remember that the chest leads, or leads V1 through V6, view the heart in a horizontal plane, not in a vertical plane, but a horizontal plane. So they look at the electrical activity that's going across through the heart from the front to the back. So if there's any tissue that is damaged because of infarction in that area, in the septum or around there, the leads V1 through V6 should be the ones that are evaluated. So on figure 10.3, bundle branch blocks, letter A is a right bundle branch. So we said earlier, right bundle branch is characterized by a RSR. RSR, meaning you're gonna have one peak going up and then it comes down below the isoelectric line and then it goes back up. Okay, so you see that? Again, this is also sometimes referred to as the rabbit ears. On left bundle branch block, which is letter B, and again, we're looking at V1. Either the QRS is negative or a QS complex is present. Either a QRS is negative or a QS complex is present. All right, so if we look at the at letter B, we have a QS. On the top one, we see a QS, okay? That I don't know what to call it, a point, or it's pointing down, right? That's a QS. Okay, let's move on to the next page. Bundle branch blocks, A, again, the left bundle branch block. Can you tell on letter A, is it a left or right? And so it's a left, but why is it a left? Or is it a mix of both? On V1. So letter A is a QS, right? It has a QS, so that would be considered a left bundle branch. In letter B, what do you see there? It's a typical RSR or rabbit ears that you see. That would characterize it as a left bundle branch, right bundle branch, I'm sorry. So the QS complex that you say that you see on letter A, it's a deep QS with no preceding R, can indicate a left bundle branch block. If the majority of the QRSs that you see are positive, right, but they're wide, then you call it a right bundle branch. If they're mainly negative, you're going to call it a left bundle branch, right? Or see QS, 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 it would be negative. Again, you can detect the left bundle branches by the presence of the QS. And you can detect the RBB, which is right bundle branch, by the rabbit ears. So R for right or rabbit. Try to remember that. So again, we're going to focus on the leads of the chest lead B1 to determine the presence of a bundle branch block. If there is a P wave present, that means that the problem is in the ventricle side, which right now we're looking at the bundle branches. The question now becomes, in which direction is the QRS going and how do you determine this? So starting at the J point of the QRS, move backward into the ventricular depolarization. If it is going down, it is a left bundle branch block. So remember the J point is where the QRS is going back up to and eventually to the T wave, right? That is the J point. So you come backwards. If it is going down, negative, if it is a left bundle branch block. If it is going up, positive, it is a right bundle branch block. So let's look at checkpoint questions. Hello, 10.2. Letter A. What do we see in letter A? What kind of wave are you looking at? QS. A QS, right? So it's going down. So that means this would be a left or right bundle branch. If you said left bundle branch, you'd be correct. Left bundle branch. Remember, the left bundle branches are characterized by downward, or call it negative QRS, but it's just a Q and an S wave. Q and S, and it goes back up. That would be your T wave. There are no P's. In this case, well, there is a very small P. It's very hard to look at, but you can see a very small P wave. Then you have what looks like an inverted QRS. It's just called a QS. Now, if you look at B, it looks like a bird's beak. You want to look at it that way or call it whatever you want. You have what? What kind of wave do you look at or see? You have the typical R, and then comes back down S, and then it goes way back up, right? It's a very tall peak. That's called your another R. The R is R. Or what is another name that we're using for it? The bunny ears or rabbit ears. Okay, so right there, top one is left. The lower one, letter B, is your right bundle branch. That was pretty short. Okay. Okay, so continue on the multiple choice chapter review questions, complete that assignment. And, but most importantly, practice on the rhythm identification, which I think it's critical because you need to make practice. Look on page 254. Just by looking at number 18, is it left or right bundle branch? That one would be right. You see the right rabbit, right? The rabbit ears. 19 looks the same. Again, rabbit ears. 20, you have the QS wave, then your T. If you look closely at the P waves, I don't know if you can look closely, but they look inverted. So what's number 19? I forgot to mention, right, that we're supposed to name the underlying rhythm. Well, I didn't mention it early, but right now I forgot. So if you look at 18 again, you can see sometimes P waves, some of them are biphasic. Like the very first one on number 18, you look at the P wave, it looks like it's either inverted. And can you see? And it's very small, but it looks like it's inverted. Okay. So that would mean that it's a AV rhythm, atrioventricular rhythm. What would be the rate on that one? Are you able to determine a rate? Let's say it's a regular rate. Remember to use the methods, the 300 method or the 1500 method. You count the big squares or the little squares. If you count the big squares, you divide them into 300. If you count the little squares, you divide them into 1500. So we count the big squares, is 1, 2, 3, 4. 4 into 300, it gives you about 70 some. Or no, actually it's lower than that. 300 divided by 4. It's 7 is 28. 2, yeah, about 72, 73. So the rate is about what? Did you calculate the rhythm? It should give you about 70 some, I think. 72, 73. So again, name the underlying rhythm. If it's the P waves look abnormal, that means they're not coming from the SA node. So they're probably coming from the junctional area. So this is a rate of 70. We call it a junctional escape rhythm with what kind of block? A right bundle branch block. Look at 19, same thing. Look at the P waves. It looks like it's inverted or biphasic. If you look at it closely, same thing. Look at the rate, the regularity. 20, the same. The P waves are abnormal. What's 21? Is it a right or is it a left? It's a rabbit ears, right? Would be a right bundle branch block. Okay, let's just quickly look at a couple of them here, like at number 22. Remember, you gotta list all the criteria, right? Is the rhythm regular? Get your calipers, measure, or I like to use 2 fingers, right? It looks pretty regular. I would say regular rhythm. What is the rate? If it's a regular, you can use any method. You just use a 5, use the 6-second method. I would probably say it's 50. Are the P waves present? Yes, they are. They're looking up, they're pointing up. Okay, looks like a sinus rhythm. PR interval. The PR interval, you can't really count it. 1, 2, 3, 4. 1, 2, 3, 4. It looks about within the normal parameters. So it's between 0.12 to 0.20. QRS, well, this one looks a little bit weird, right? So what is the interpretation? We'll call this a sinus Brady with what kind of block? A right or left? What kind of block would you call it? Right or left? I would say this is a right bundle branch block. Because all the QRSs are pointing upwards, okay? And you give the RSR wave. Although this one looks a bit different than the other ones, it's still R, goes up, come back down, S, and then R again. So you have RSR. So this is a rabbit ears. It kind of looks like the opposite on the other ones that we've seen. The small one is on the left side, right? And this one seems to be on the right, but it's still a right bundle branch block. So continue with your practice on rhythm identification and you get practice so that you can master these two. These are very simple. There's only two arrhythmias. After this, we're going to continue with pacemaker rhythms, which are also very easy to spot, very easy. It's I believe it's also a short chapter that you'll be looking at. But it's very easy, so to help you identify those pacemaker rhythms very easily. When you see them on the EKG, very noticeable. So for right now, where you're done with bundle branch blocks, make sure you complete those rhythms, that practice, so you can master these. And we'll see you on the next chapter, 11.